Hi, Joe, coming at you with a good friend of mine, Justin George, who's a doctor of pharmacy. He's a clinician. He is a hospital pharmacist, and I want to bring him on today for the podcast because we did a previous podcast on the topic of, hey, I'm a newly diagnosed type 2 diabetic. What's gonna happen? What's next? And we covered some things on that I really think you should check that podcast out or video if you haven't seen it or listen to it. And now we're going to talk about the next thing that we want to talk about is once you're diagnosed, what kind of medications are you talking about? Because this is where there is some cost with testing and all that, but this is where the costs come in. But also, I think the disconnect that a lot of people have is they don't understand that this is only going to probably go up if this disease is left unchecked and really not controlled well with the lifestyle modification. So, Justin, I know you and I talked about this before, but let's talk about. I'm newly diagnosed. What are some medications that they're going to start me out with?
Yeah. So once you are diagnosed with diabetes, so meaning that you have an A1C, hemoglobin A1C of 6.5 or higher, then the next step is to see how uncontrolled your sugar is. So for the vast majority of people, you're going to be, started on metformin. So metformin is an oral medication. It's been on the market since about 1995 in the United States. It is actually the only medication in its class that is approved in the United States. So there was another drug called fenformin, which was taken off the market in the early 1970s. So, Joe could tell you about that. He's been around since penicillin. I'm just joking.
I've been around. He's just got out of med school when I
Don't worry, I'm sure someday, later on in my career, people will be like, "Oh, do you remember what it was like when Xarelto was a brand name drug?"
Oh, they're gonna be some snot-nosed kid that's gonna bust your chops.
Yeah, there will be.
I remember when I picked on Joe. Now he's picking on. Yeah, now it's gonna happen. It's called karma. It's gonna happen.
But yeah, so metformin is going to be usually the first stop.
Yeah,
and it's got a lot of different effects on the body, and metformin it's a very interesting drug. It actually can help with weight loss. It's available in an immediate release, but also an extended release formulation. And in general, it is a fairly affordable medication. It's not a brand name drug anymore. It's generic. It's available in, a lot of different, pharmacies and formulations and things like that. But that is the first step. And after that, if, you're not able to keep your sugar under control, if you're not able to tolerate the metformin because it can have a lot of GI upset. Some people get a lot of, stomach issues, nausea, vomiting, diarrhea with metformin.
Yeah.
And if that doesn't work, or if your sugar is still not controlled, then they might add on another oral medication.
Such as?
So then once you're adding on meds on top of metformin, there's a ton of different sulfonylureas like glimepiride, glipizide. You've got DPP-4 inhibitors, so drugs like Januvia, Tradjenta. Yeah. You have, things like acarbose, which are meglitinides, which aren't really used very often. Mm-hmm. You've got, a bunch of different medications. So let me just take a look, because I have a whole list here because there's so many. So you've got SGLT2 inhibitors, which are fairly new, and you might see commercials on TV for those, like Invokana, which is canagliflozin. Jardiance is another one, and Farxiga. Those two, I think there are a lot of commercials on.
No, Justin, is that the one that helps excrete glucose to the?
Yeah, so the SGLT2 inhibitors work by increasing the level of glucose that's excreted through the kidneys. And so it's kind of an interesting mechanism of action, because it's actually using the kidneys to kind of, pee out the sugar, essentially.
Yeah.
Which, when they were going through their clinical trials, I was in college at the time, and I actually had to do like a scientific, literature project on it. Yeah. And one of the concerns my group had was, what's that going to do for, UTIs? Because you're putting sugar out, and that can only increase the risk of infections, but there's actually several medications approved, and some of them actually have indications for heart failure. So it's very interesting. So that's one. Those are some of the classes. You've got TZD, which is drugs like Actos or pioglitazone, not really used as much. And there's a couple of other classes, but the most common ones are things like Januvia, glimepiride, glipizide. Those are usually the ones that are added on for on top of metformin.
First, and then tell me about some of the injectables. You see all these ads, Ozempic. Some of them drive me crazy because they're like, "Look, your whole problems are going to be solved by taking this injectable drug." Talk to us about Trulicity, Ozempic, Victoza. I guess they're all in the same category.
Oh yeah, so those are called GLP-1 agonists. So Victoza, Ozempic, Trulicity, and there's so many different ones. There used to be, back in the day, there was Byetta. I don't know if you remember that one. That was like in 2005 or so. And then they had a long-acting version of that called Bidurion, which I believe was like once a week or something.
Yes.
So they all basically work by, acting on how the body handles sugar after you eat. So metformin is interesting in that it actually helps with your fasting blood sugar. Most of the other classes of medications only work on your postprandial sugar, which is after you eat.
Right.
And that's where the GLP-1 agonists come in. And by extension of that mechanism of action, they can also promote weight loss. So I think Saxenda is indicated for weight loss, which is basically a higher dose of Victoza or a different dose of it.
Yeah.
And so, kind of have different indications. And of course, they make more money that way. They rebrand it and give it a different indication so they can charge accordingly. But, the thing with all of these medications is that it's only going to do so much. What it comes down to is how many carbs you're consuming per meal, how the type of carbs that you're having, because oatmeal is going to spike your sugar differently than eating a giant cookie, a Panera cookie that has 30 million M&Ms on it. And how you manage your diet, how you manage your exercise, and your lifestyle is going to impact how well these medications work. So,
yeah, I think sometimes there's a false reliance. That's why some of the commercials, I know the pharmaceutical companies have to put the word out, but some of the commercials make it sound like, they don't have to do too much. They will give some lip service to lifestyle modification, but it's surprising. But now, after that, Justin, let's say, we're treating the diabetes, it's not coming down, or maybe it's coming down a little bit. What are some other medications can people typically going to be put on if they're a type 2 that are kind of, I guess, treat the comorbidities of cardiovascular, hypertension, hyperglycemia? What are some other ones you're going to see?
Yeah, so along with diabetes, we know that it causes a lot of issues in the body. So the level of sugar that's hanging out in the bloodstream, the more sugar that's there, the more damage it does to your blood vessels. It wrecks your kidneys, it wrecks your heart muscle, and it affects your nerves. So basically, sugar is almost like a very corrosive substance in the body, and your cells need it for energy. But if it's hanging out in places where it normally isn't, it's going to be causing problems. So one of the things that is so important with diabetes is making sure that you're managing all the other risk factors that come along with it. So you're at higher risk for stroke, you're at a higher risk for heart attack, and one is that they may not realize they're having a heart attack, especially if they've had diabetes for a very long time. So my mom is a diabetic educator, and she's treated diabetics for many years. And more often than not, there are patients that come into the hospital that have, a heart attack, and they may have not realized it because their nerve endings in the chest are so damaged.
Wow.
Years of uncontrolled diabetes that they didn't even feel it.
Didn't know that.
That's one of the reasons why you hear about diabetics getting like a toe amputated or a foot amputated or even an arm or a finger, because they might hit it somewhere, or they might step on something, get a cut, and not realize it for days or weeks, and it gets infected. And then, of course, by the time somebody realizes it, it's spread to the bone, and then they have to be on antibiotics for weeks on end. And you see it time and time again, and it's so important to get that sugar under control, because it leads to a lot of other downstream effects. So in line with that, most people might end up on like an ACE inhibitor or an ARB, which is a class of blood pressure medications, and they have a lot of different kinds of effects. So it helps with cardiovascular mortality. It helps reduce your risk of heart attack, heart disease, and stroke. but it also helps actually kind of protect your kidneys in a way.
Yeah.
Not really, it's not really fully understood, but ACE inhibitors and ARBs do have some kind of kidney protective effects.
Yeah. Yeah. So you're going to probably see a medication for blood pressure, even though you might not have it, but it's for you to protect your renal function. You're also possibly going to see some things to keep your triglycerides down or your hypoglycemia. A lot of times they'll put these patients on a atorvastatin. I've seen that quite a bit. So you're looking at some other medications, and unfortunately, and then just we're going to wrap this up with where insulin comes in. But unfortunately, you're also going to be looking at more increased risk of infection, which I think is terrible. More coughs, more colds, more things like that. You talked about some of the more severe ones, but typically my type 2s catch a lot more bugs, if you want to call it that. They get more upper respiratory, and I see them being a little sicker than the rest of my patients. Now let's talk briefly about insulin, because there comes a point where some diabetics, after the doc starts to have them test 3 or 4 times a day, and they're not getting the results. And now we put insulin in there, correct?
Mm-hmm. So insulin is the pretty much like the end of the therapy, because once you reach a point that you need insulin, that means either you've tried all the oral medications and it's not working, or you're not able to tolerate it, or you might be a type 1 diabetic and you'd have no insulin production in your body. So insulin, there are many different types of insulin, but they're basically all made through recombinant DNA technology now, which is they grow the insulin in cells and they harvest it, and it's all purified. Back in the day, they used to use porcine insulin, which is from pigs. Mm-hmm. And the problem with that is people with allergies to pork, or if they have any kind of sensitivity to it, or people with religious sort of observances where they can't consume pork derived products, then they weren't able to take that insulin. But in the early 90s, late 80s, that's when the recombinant technology started coming out. And so there's a couple of different types. So you've got regular insulin, which is Humulin R, and that usually has like a 30-minute to 1 hour onset. You have your long-acting insulins, which some like Elantis, or what's the other one? Tresiba, which is insulin degludec. Yeah. Then there's also Levemir, which is technically 24-hour insulin, but it's more like every 12 hours, depending on how you dose it. But those are your long-actings. And then you have your rapid-actings, which are really quick, which are usually given after you have a meal. So those are like Humalog, Novolog. Yeah. There was also an inhaled insulin that was available for a while. I'm not sure if that's still on the market.
No, that didn't do so well. That's gone.
Yeah, that didn't really take off too well. It's probably too expensive anyway. So
one of the things too about insulin is a lot of patients of mine say, "Oh, I don't want to go on insulin." I said, "Well, look, probably it's going to be the best way at a certain point to control your diabetes. Your blood sugars, your glucose levels are going to be more controlled with the doc dialing you in with insulin. So don't be afraid of it." And I know what they're thinking was, now I'm going to have to be dependent on this. Well, your cells have become desensitized to insulin. So probably at that point, you may never see a reversal. But what you can have is a much more manageable thing. And I think I want to end with that and say, again, because I mentioned this in the podcast, even when you get to a stage where insulin is now needed, Justin, these patients, if they really try to do some lifestyle modification and really turn things around, they can have a much better control and maybe reduction in some of their amount that they need of medication, but also their outcomes could be a little better if they said, "Hey, look, I'm at this point, but it's not too late." And I think until they start, doing amputations and everything else, it's not too late, So I'm not a fearmonger. But I'm trying to explain to patients, and I hope they understand that even this disease state, when it starts to progress, it's not too late. It's not, right?
Yeah, definitely. I mean, I think it's easy to be scared, especially as a newly diagnosed diabetic, when you're seeing everything in the news about insulin prices. I mean, you've got drug prices that are at the forefront of every sort of news article that's out there. And it's something to be scared about, but it's something to be, that you take that into consideration and use that as motivation to continue to follow up with your doctor, to ask all the right questions, and making sure that you advocate for yourself, because unfortunately in our healthcare system, you have to be your own advocate, or you have to have somebody that's knowledgeable enough to advocate for you. And
Absolutely.
it's a tough system to navigate. I mean, even for people like us, I mean, we've been in the healthcare field for a long time, and even for us, when we get sick, it's almost like a labyrinth to navigate. And I think the biggest thing is to not be overwhelmed or get bogged down in all the details, but just make sure that as long as you're taking action now, you're going to help prevent a lot of headaches later on.
Yeah.
And everybody's at a different sort of point in that life cycle, but as long as you're making that choice to get better and to be more informed and to learn, I think that's a good first step.
Well, I appreciate taking the time with us today. And the one last parting thought I want to leave for the people on the podcast is go to rxhealthyhabits.com. We have a lot of great information there about some healthy habits. We got some good recipes in there. We got some blogs that are really informative. I'm really proud of my blog writer. Podcasts have started. This is one of them. But we have a lot of information I think it's going to help you really on your journey, because it is a journey. Your health is a journey. And even after a diagnosis like this, you might say, well, what's the sense? No, all the more reason to really say, you know what, I really can make the rest of my life, as far as my health goes, much more smoother if I do jump on board with some of these habits. So, Justin, again, thank you so much. I don't know. I think I got another topic on this that I want to have you talk about at another time. I think we really need to dive into some of the comorbidities a little bit more, because I think people need to know that cardiovascular risks and some things they could do there too. So again, thanks so much. And I look forward to seeing you on the next podcast, my friend.
Thank you, Joe, as always.